guys, I'm going to give you just a short review here of a couple things to make sure that you're on the right track with your test review. The first item here, just know that safety is our absolute first priority as professional nurses. And, you all have been exposed to many ways through the Speak Up campaign that patients are kind of encouraged right when they get to the hospital. If they see anything that needs to be brought to our attention, that we do that, and how to really make them feel like they're part of the team for safety. The most common error in hospitals still, even with all the efforts that we've done, continues to be medication errors, so remember that. SBAR is a standard communication tool that we've focused on quite a bit. Make sure you remember those components. It's important to always use that method for communication so that our caregiver communication from one person to the next on the team of caregivers is improved, which is one of the National Patient Safety Goals. We talked a lot about examples of how continuous surveillance monitoring helps identify trends or patterns of changes in condition much faster than vital signs, for example, every 4 hours. Know the definition of practice drift that's in the slide pack. Also, you all gave some great examples of practice drift, so I'm pretty sure if you see some of those as examples, you'll be able to pick those out. From our guest lecturer, we had a lot of examples in the slides in terms of the typical body systems that begin to fail with age. Make sure you can pick out which ones of those that are definitely affected, and symptoms that you would see in elderly patient common based on those kinds of declines. Know that the percentage of delirium, the guest speakers gave us some real clear-cut examples of percentages in terms of how many elderly patients in the hospital setting and with certain kinds of conditions like fractures or surgery have and experience delirium. And then, all the symptoms that are listed on the slides in terms of what you see with delirium. And also how we talked a lot about in class examples of how you would do nursing interventions to kind of reduce delirium and how that differs in how your approach would be to dementia patients. The book talks a little bit about poor appetite in the elderly and what are some of those common causes. Probably when you're trying to set out to do an assessment, in terms of how well is an elderly person eating or if they've had weight loss, you want to really look at probably environmental factors first. Do they even have food in the house? Do they have finances for food? And then kind of work your way down. If they have food, then, what is the types of foods that they eat, or do they have dentures that fit properly? Do they have any sores in their mouth that could be preventing eating or swallowing? And then kind of work down to do they have any malabsorption issues, and what is the typical food they'd eat in a 3-day period to get an idea of their norm. But if they don't have money and they're going back and forth they don't have a way to get to the store but ever so often to get food, those are kind of the beginning things you want to ascertain first. There's a lot of ways that people have devised to help elderly people self-administer meds correctly. Your book gives some very good examples of that. One of the key things when they're getting several different meds but all at different times, like some of them are once a day, some of them are twice a day, some of them are 3 times a day. If you can come up with a color coding system for the bottles that lets them know this one I take twice a day, this one I take 3 times a day. That is a simple thing that helps people. Now, the caveat to that is you better make sure that they don't have, color blindness, which some men do have. But as long as that's okay, that tends to work easier for a lot of elderly patients versus sitting down and putting them all into a pill box for them, and organizing it on a list of paper that's hard for them to follow or read with their vision issues. So think simple is always best. Um, just knowing with pain management for the elderly, they talked a lot about how, mostly elderly patients are under medicated. People tend to think they can't take strong drugs after surgery, for example, or, when they have severe fractures or something. And that's just not true. It's just that they may need lower dosages of the strong medication, or they maybe need to be watched for how well their absorption of, half-life is, an issue sometimes with drugs in the elderly, where they kind of hang on to drugs because they're not excreting them as fast as someone else. And so just kind of recognizing those things are at play. But if they have severe pain, they need to receive medications that are, strong, that would be given to anybody else, and just look at what dose adjustments you might need to do. Actions, we talked a lot about a good example of informed consent. And the very best thing you can do when there is a concern about a patient who's confused or intermittently confused is go to the entire healthcare team. Discuss this as a team, because everybody needs to be consistent with who we have ascertained is the next of kin, and it doesn't need to go down the line. I have seen people call and get consent for the primary person that's supposed to give consent, whether that be a healthcare power of attorney or next of kin. And when they have not been able to get that person, then they somehow think it's okay to call some nephew and get consent. So just know that it's not a variable condition. There's a person to get informed consent from, and that's who you need to be going to. And everybody on the team needs to be first and foremost apprised of, we all agree who that is first. We talked about what issues come up with assessing capillary refill with folks, and I feel like y'all had a good understanding of what is the normal amount of seconds, what would constitute an abnormal amount of seconds. You will need to pick that out from an example given. In terms of intermittent claudication, we know that patients with peripheral arterial disease will have, pain with ambulation that gets worse the longer they're up and moving, and then sometimes it will improve with rest, or that's the typical. Occasionally you have somebody that has more constant pain, but the norm is that it's usually relieved a little bit with rest. And then, so when you're trying to do structured exercise for them, it needs to be kind of go slow but be steady. And, if pain medication needs to be given as a, try to use what you can that will assist them to, gradually get into a more structured exercise program. We've talked about this many times, potential barriers to foot care. People have big, thick nails. They can't cut them properly. They can have nicks or ingrown toenails. They can have very poor sensation, so they don't recognize when there's wounds or issues or infections. So just really trying to educate people as to how to care for their feet properly. Sometimes they're not able to physically bend enough to get to their feet to wash them or care for them as well. For patients that have had PTCAs, we know that anytime that you are going in through a vessel to open up a vessel with balloon, you want to be, and with surgeries also to any of the arteries, like for bypasses, we want to be primarily concerned with what is the circulation to that affected extremity, and how does it compare to the opposite extremity, and looking at return of circulation and really watching those pulses religiously, marking them so we can all tell where they're at. and be feeling for it in the exact same location for consistency is also a big thing. Your book talks a little bit about throbbing pain after you've had a bypass. You want to be able to, expect that there may be some of that, and that may be normal. You may want to have them already planned to, obviously, they're going to need pain medication, maybe even a PCA for pain following surgery. Just like the example in your heparin drip protocol that we worked on, the patient developed confusion after having an anticoagulant. And anytime that occurs, you have to think, is this a brain bleed that is occurring as a result of that medication? And it is a critical event. Rapid response needs to be notified. The physician involved needs to be notified. And, typically the patient's going to be emergently sent for a CT scan with infusion, if they can do it with infusion, because they need to really ascertain, is this a bleed in the brain or is this a clot that's been thrown to the brain? And obviously one's going to not be treated with further anticoagulation while the other one might need further anticoagulation. So just know those are kind of the typicals. When you have a patient with a abdominal aneurysm, our normal thing for assessing abdomen might include, for a typical patient, palpation or percussion even. And these type of things you want to avoid in the abdomen and chest cavity because it can really cause more damage if you suspect an aneurysm. We talked a lot about prevention goals for DVT, movement, SCDs, TED stockings, use of Levinox or, sub-Q heparin, getting patients up and out of bed as early as possible. All those things together are very important. Comfort measures for phlebitis, that was on one of your slides. It just talks a little bit about how warmth can be applied, and we talked about proper ways of doing that and ways in which you want to be careful so that people don't get burned. Know that with weight loss or gain, you want to have anti-embolic stockings or TED hose that are providing the compression but are not too tight, which they can cause actually literally decubiti cuts in the skin from pressure. And you don't want them too loose because they're not then doing what they're supposed to. And they need to be the right length and width, and that's why we measure them. So just know if you ever have a patient that has, significant weight loss or gain, you want to re-measure them for that. Know what type of teaching needs to be done after somebody's had post-DVT and been put on warfarin. That was one of the handout things that you had. What kinds of things would be required? Somebody's going to have regular lab work drawn and follow up with their physician in probably 5 to 7 days after that to double check, what are their levels, and that's required. Obviously, we discussed risks that can come from decreased sensation. People can have falls, injuries, wounds in their skin that they're not aware of. Let's see. Y'all saw the video about ankle brachial index and how that works. Let's see. And then just things that help us do better critical thinking. That's on your slides. Know the components of SHARE for caregiver communication. There's a list of things associated frailty in elders, symptoms that you would see when they become frail, and then foods that are really recommended for elderly patients. Common adverse medication effects that you would look for in elderly patients are from those slides that they had.